we've come to the end of our presentations, and I would like to just invite all our speakers tonight to unmute themselves and activate their videos so we can get into the interactive part of the evening, the panel discussions. We've got a board full of questions, which is great. So we've got Guy and Ian and Philip's on too as well. Okay, I've got one to start off with for everyone. I personally believe the quality of the audit comes from starting early and starting with junior staff. You know, if it's ingrained in them, then it becomes second nature, and they're the future surgeons who will follow this as though it's a you know, indoctrinated into them. Are there any data from ANZASM, VASM, as to how many of the trainees are involved with the collection of the audits?
I'm not entirely sure we know that number, but I think it has been suggested about a third are either the data is entered in by the trainee, and we are able to measure it, but you've asked a question which we could have prepared for, but we weren't. I'm sorry.
I think, Patrick, it should be part of their training. They should be said, okay, you sign up with the College of Surgeons, you will get all this stuff from VASM, so they're aware of it. And at the moment, I think a lot of them aren't aware until their boss says to them, can you please fill this form in? Mm. And then they go, and they get a bit sort of blown out by it.
It's almost like it should be part of you know, the college requirement for them. Is it the college requirement for the trainees?
No.
No, that's it. Yeah. Just wondering whether they can be.
I mean, I was reflecting on this the other day. I have about between sort of 5 and 8 deaths a year under my name, and I usually get the fellow or the trainee to fill out the form. I do that not because I'm lazy, although probably that's partly true, but it's actually and then I can look at it and say, well, actually, yeah, no, that was the way it was, because I find when I fill them out, I tend to sort of reinterpret it all a little bit to try and explain why we did what we did. But the trainee often doesn't do that, and I think that's been quite a useful manoeuvre. But of course, you then do have to read it and make sure that you're comfortable it's accurate.
Ian, your experience?
I think it's always very informative to read the notes that have been written about your own patient, especially if you can do it in a timely manner.
Yeah, totally agree. So here's a board of questions. Okay, we'll start from the top. So first question, the data is very useful and underutilized. Is the data available for surgical groups for research, perhaps particularly to the Joint Arthroplasty Register allows surgeons to use their data?
Well, I can answer that. It absolutely is. I mean, we have a process where you put forward what you'd like to look at. We make sure we have a committee that looks at it very briefly and just make sure that it's an appropriate use of the data. And then we will facilitate whether you want to look at it at a Victorian level or at an Australian level. We will help you do that, and we encourage it. And we have approximately 70 publications that have come out of the audit data so far, and they've come out of every state, and from medical students through to, you know, very senior consultants.
Yeah. In the same vein, then, other colleges, can they gain access to this data? You know, to GPs, emergency med, anaesthetists?
Well, again, if I could answer that, it's in theory they could. We've had 1 or 2 applications only, and sometimes they've turned out really not to understand what the data looks like, and we've had to say that, well, you can have access to it, but the question you want to ask can't be answered from it. So no, it hasn't been widely taken up by others, but there's no block to that. But we would probably want them to be doing it in association with a surgeon as well, because there is a need to understand what you're looking at.
A new question: should we have an educational session about VASM as part of the training program? Maybe directed at Phil.
Yes.
Well, succinct, very succinct. I know we've been talking about that during the course of the year, but yes, we've been really trying to get involved in all the junior trainee programs. I think urology was thinking about it, wasn't it?
We were going to have one, and of course COVID came around and it just didn't happen. So, but using this sort of technology, it should be quite easy to do now. And we can either pre-record stuff as Erwin did earlier, or we can have an interactive one like this. It works very well.
So COVID is a gift that gives on giving, as expected. All right. So next question, I can see that the public system is the main source of data. How compliant are the private hospital who may not wish to disclose or acknowledge any CMI involvement in their hospitals?
They all sign up for it.
Yeah.
So yeah, we have 100% hit rate, certainly in Victoria. Every hospital is signed up and will give us data. I'm a little concerned. I think I'm looking at some of the VAHI data at the moment, and I think there are a few holes, and we're going to compare the VAHI data with our data and go back, and if there are holes, go back to the hospitals and say, you haven't been reporting everything. And it may just be, I don't think there's anything nasty in it. I think that it's possibly one of these jobs that's just given to the probably least experienced people in the hospitals, and they may be not understanding what they're doing or the importance of it. So a little nudge saying, look, you haven't been necessarily reporting everything might help.
I can certainly see in all our data that you've been reporting over the last 10 years, the percentage of uptake. I think you remember it was like 50-odd% or maybe less, but now it's very close to, well, it is 100%,
yeah,
which is great. Fantastic. Okay, next question. Question around moving to reporting aligned with the financial year. Annual reports are the same in Australia and New Zealand. Financial years are not the same in both countries. New Zealand has a fiscal financial year and a company personal financial year in UK. Would it be reasonable to stay with an annual data set?
Don't think it matters a great deal. We don't actually get any New Zealand data. So even though we are the Australian and New Zealand order of surgical mortality, where we don't get New Zealand data. So yeah, Guy will know more of the details about that than I do, but maybe just because ANZASM sounds better than ASM, which is what it would be if we didn't have New Zealand involved.
Yeah, look, the situation with New Zealand is we wanted, of course, we're a binational college. We wanted to have New Zealand feeling that it was being involved. It has a different way of looking at mortality. It's not wanting to adopt our data set. It feels it's not appropriate for New Zealand. And so it's got its own system, which we have no direct engagement in, and it's run by their Department of Health. So we would welcome them at any time. We've absolutely tried to encourage them to take our data set and use it. But I guess this is always the issue when you have two countries. They always want to do things their way.
An earlier question for Phil. You mentioned that there was a conflict of interest for you looking into the second line assessment. Why was that said?
Well, I review them all anyway. I review every case that comes through, so I shouldn't really be reviewing my own assessments.
Mm-hmm. Makes sense. Good. Another question. Agree with that M&Ms are incredibly useful. There are still solo private surgeons in private hospitals where M&Ms are impossible to run. What measures can be undertaken by ANZASM, VASM, RACs to improve the ability of the non-public hospital surgeons to be involved?
Well, I mean, I could just throw something in. We have a surgeon that works in one of our peripheral hospitals, and he's a solo surgeon. And every 6 months, he brings all of his data forward for a discussion. There's, relatively few mortalities. It's a very, it's a hospital that would tend to send on most difficult cases. But we do that, and we do that as part of our sort of outreach to those sorts of organisations where you do have an individual. And I think the same could apply to a surgeon who works in a private hospital in Melbourne and doesn't necessarily have any engagement with a public hospital, and I can't see any reason why they can't attend, bring their data along and have it reviewed by a group of colleagues. And that seems to have worked very well for the individual that we've been working with, and it's endured over many years.
That's good. Now, something about the forms. Has the process of form completion improved over time as the process has become mandatory? If a surgeon repeatedly requires a second-line assessment, mainly because the form has been completed poorly with little detail, does this feedback improve the form completion quality? That's a good question.
I would say yes, it has improved over time, and I'm sure Guy would probably have the data to support that as well. Yes, there are individuals who will not complete forms adequately and really give us very, very minimal information. What we're hoping is that obviously the situation in Victoria has changed recently, that all the second line assessments are now identified. Until the middle of last year, they were all de-identified, which took an amazing amount of time to take all of the hospital and patient and surgeon details out. That's stopped. So the second line assessors will now be noticing, yes, they know which hospital, which surgeon, name of the patient, all that sort of thing. They can't obviously divulge it because of the QP issues Guy talked about earlier. But we're hoping that the fact that this information is now available and slightly outside might shame a few people into giving us a little bit more information than they have done previously.
Yeah.
So I would hope that our second line assessments, because of any adequate information, will decrease over time. We will keep a close eye on that.
Anything to add, Guy?
No, I've nothing to add. I think that's absolutely right.
Yeah. A couple of other questions. It would seem that surgeons who perhaps would benefit most from assessments are those who do not participate. What can be done to engage this group of recalcitrants?
Philip,
Loaded question. There you go.
We know certain people don't like filling forms in. I've jokingly got a naughty list of people, which I think at the beginning of the year was about 200 uncompleted forms. We've managed by various mechanisms to get down to about 50 or so. So really be pestering them, saying you have to do this. I think the CPD thing helps. So people do rush in their forms towards the end of the CPD year. So there'll be a whole load of forms, I'm sure, turning up in January and probably early February to try and make sure they're signed off for the CPD year. And the other tool we will have available once the QP issue with the VPCC is available is that the VPCC can actually then go to people and say, oh, we haven't got this information from you, can you please do it? And they've got much more clout than we have. So that's something which, if the form hasn't been returned to us within 6 months, we can possibly say that now. In the future, the VPC might be asking a few questions.
I think the core of all this is that this is an educational tool. I mean, every accurate information will help teach us as surgeons. I mean, surgeons learn every single day. And I think that's the key message that should be sent forth to our colleagues.
I think that's one of the things I was trying to get out of that reflective thing I showed in my talk, in that either by design or because they couldn't be bothered, a lot of people appear not to take it that seriously. And I would have thought that when people die under my care, it's pretty devastating. And you think, could I have done something better? And to have only a third of the surgeons where we think something has gone wrong to have actually said, you know, they've all said, yes, my care of this patient was perfect, in effect, which I think lacks a certain amount of insight, or they haven't put the time into the form.
Can I just interject on a slightly different note? But and of course, we do focus, as Ian said in his talk, on the negative side of this because it's a death. It's always a bad situation for the family and for the patient very often. But I thought Ian's point was quite interesting about sort of positive messages. And it's interesting that that's come up because it was only what I think, Philip, in the last couple of weeks, we've looked at a case report which will be published in Surgical News, where it's the first time we've actually published a positive story about a surgical death. And basically it's a case where the team performed brilliantly in managing what was really an unsalvageable problem and almost without blemish. And the patient, of course, succumbed. But it was I think we need to do more of that. We have tended to fixate on where we've made a dreadful mess of it, or at least could have done it a lot better. And there are certainly cases where we do incredibly well when goodness knows how we even got to do so well. And I think that's going to be something which, you know, we should be interspersing a lot more. There are good news out there, and I thought Ian's comments were absolutely right.
Ian, comments?
Thanks.
I agree. I think it's really good when we get assessments and they say this, they've pulled out the stops. They've done a really good job here. It was unsalvageable. And we do get a lot of nice comments from the assessors, which I'm sure go back to the surgeon and probably make them feel a bit better about themselves, which is good.
Actually, in the chat section, Robin Stunden has made a comment saying that in their audits, they incorporate an amazing or awesome story as part of their celebration of good care.
Yeah, that should be replicated. Yeah, we've got enough bad stories around the world. Sometimes it's good to see the positives in what we do.
Well, every time I talk about these things, I do stress 75% of our surgical deaths, no one's got any criticism at all. They're just saying, yeah, nothing could be done. And the overall mortality rate is world leading. So we're doing pretty good.
We might finish with one more question. Is the system used by others around the world? And can we share data? You know, the ANZASM equivalent around the world, can we share data?
Look, I probably should answer this one. James Aitken in Western Australia started this whole process by taking the Scottish audit of surgical mortality and bringing it back to Western Australia where he got it started. And then once it was working well, the college took it over. We have kept James very closely involved. He's absolutely integral. We rolled out across the country. Interestingly enough, the audit of surgical mortality in Scotland, about 8 or 9 years later on, folded. And it was for a lot of reasons. They are now coming back to us and asking how to run the audit. And we've been giving them advice. So we are not aware of any other process that we are taking, but we did not develop it. It was developed by the Scottish. They made a mess of it, not the surgeons, the administrative issues. And now they have actually come back and wanting to learn from us. So no, it would be fantastic if you could get this data set collected in, say, you know, the developed world. It would be really interesting, but I think we're a long way away from that.
So we've come to the end of the webinar. I'd like to take this opportunity to thank all of our speakers, Ian, Guy, Philip, thank you very much for your time, and also Erwin for recording previously. To all the attendees, thank you all for attending. The attendance of these webinars may accumulate some CPD points, depending on your respective colleges. It's very difficult, I know, to put aside time to attend these webinars, but I hope this first one has whet your appetite to register for the upcoming webinars.